All right, guys, welcome back to it. So today we're going to be talking about a big disorder, but also a disorder that I would say lay folks probably have a pretty poor understanding of. And so for that reason, we're going to be focusing exclusively on this one disorder today, which of course is schizophrenia. I do want to point out, though, before we get started, that schizophrenia is one of several psychotic disorders. So it is not the only diagnosis within the DSM that is defined by the presence of psychosis. But again, this is the only one that we're going to be focusing on today. So, what is psychosis? Psychosis is a term that's used to describe someone who is generally considered to be out of touch with reality. And typically, this is a combination of unusual thinking patterns, distorted perceptions, and odd behaviors. The hallmark symptoms of psychosis are delusions and hallucinations. Delusions are false beliefs that someone has. Typically, these are really rigid in nature, meaning that you can try to debate or argue with this person about what it is that they believe and kind of explain to them, why it's false and not based in reality. But the person's belief is very rigid and they're unlikely to be swayed despite this type of conversation. A hallucination is going to be any type of false sensory perception. So this would be seeing, hearing, smelling, tasting, or feeling something that is not based in reality. One thing that I would like you guys to consider on your own, and feel free to kind of flip back through past notes or lectures if you need to refresh, but think for a moment about a couple of past diagnoses that we've talked about that have involved either delusions or hallucinations. There are several, so these are definitely concepts that you guys should be familiar with at this point. And my aim in pointing this out to you guys is that while delusions and hallucinations are the hallmark, the core of the psychotic symptoms, just because you see a delusion or a hallucination in a patient does not automatically mean that we're dealing with psychosis. Again, there are a variety of reasons for these symptoms, but the main kind of predominant reason, the reason that clinicians will frequently go to first, is psychosis. So again, something important to recognize: the hallmark nature, but also the nature that it's not an exclusive kind of diagnostic feature to psychosis. Beyond that, psychotic experiences may also be associated with a variety of medical illnesses, Alzheimer's being a prime example. They can also be associated with brief or limited psychotic experiences. Brief or limited psychotic experiences are experiences that typically last for maybe a period of a few days, which is really brief. And you guys will get a better sense of that as we get into the true duration of these big diagnoses like schizophrenia. So a limited experience, again, lasts a couple days. And it's typically associated with a stressor. Most commonly, we'll see this associated with grief. So a person has lost a loved one. That's definitely an acute, intense stressor. And that can cause the person to be delusional or potentially even hallucinate for a period of a few days. One difference between these more brief experiences and schizophrenia or other psychotic disorders, in addition to their duration and the stressor induced onset, is kind of the nature of the delusions or hallucinations. There tends to be more of a positive valence to those experiences if we're talking about someone with a brief experience, meaning that, if we were to go back to that grief example I mentioned earlier, it would be more common for a person to be seeing angels or maybe even seeing their deceased loved one or something like that. Again, something that has a little bit more of a positive kind of spin to it, versus you guys will see later on when we go over examples of schizophrenic symptoms that frequently people are believing very negative, scary things or experiencing very scary kind of false sensory perceptions. So that's another difference. So, what is schizophrenia? In a nutshell, the core diagnostic criteria are very straightforward, so there isn't really a lot to learn or memorize there. But what is unique about schizophrenia is that this list of symptoms is going to be unique. It's probably foreign to you guys. And so, we're going to spend a lot of time fleshing out what each of these symptoms is. So, that's one of the things that's really going to take up the bulk of this lecture. So, simply put, in order to diagnose schizophrenia, a person must be experiencing at least two psychotic symptoms over a 1 month period of time, potentially less if successfully treated. So, what this means is that because the symptoms of schizophrenia and just psychosis in general are so hallmark, and they can be so intense, if there's a family history of schizophrenia, or the person happens to be around somebody, a friend or a family member who's familiar with schizophrenia, like a therapist for instance, and that person or that family member is able to intervene, say, hey, like, I think something's going on, we should go to the hospital, and the person's diagnosed and treated sooner, then their symptoms wouldn't meet that 1 month threshold. But because schizophrenia is so chronic in nature, we can assume that if the person weren't treated, that their symptoms would have persisted longer than a month, and we're not going to let a person suffer just to see them get to that 1 month mark. So, two or more symptoms over at least a 1 month period of time or less is if successfully treated sooner. So, the symptoms that we're going to be looking for are delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, and negative symptoms, which include things like a flat affect. You'll see asterisks following delusions, hallucinations, and disorganized speech because those are going to be critical symptoms, meaning that at least one of the two symptoms must be one of those three, and then the second symptom can be whatever. And again, it's totally possible for a person to have more than two of these symptoms. Ultimately, the combination of psychotic symptoms must decrease the person's level of functioning. This can be in relation to their ability to socialize, do their job, or simply take care of themselves. And at the end of the day, we must see continuous signs of disturbance for at least 6 months, which includes the prodromal and residual phases of schizophrenia. So that's another thing that makes schizophrenia unique beyond the unique symptoms that, we haven't really delved into quite as deeply with some of these other categories or symptoms that just might feel a bit more foreign, is that we're dealing with stages and phases here. So symptoms aren't consistent throughout the entire experience of schizophrenia. So ultimately, there are four phases that you need to be familiar with. And once you get these phases down, then the duration pieces from the previous slide will start to make sense. Because some of you at this point might be starting to wonder, well, hey, like she mentioned 1 month and then 6 months. So how do those pieces kind of connect? And again, the answer kind of lies in the phases. So phase number one is the pre-morbid phase. Pre-morbid is a fancy jargony term for before disturbance or before quality of life started to drop off. So this would be childhood, teenage years, all of the healthy years of life before the person started to experience symptoms. The prodromal phase is this kind of brief phase where we're starting to really see more of a functional decline. So this might be when a person starts skipping classes or ducking out on work, or we're starting to see self-care take a dive. Maybe we're even starting to see some flickers of positive psychotic types of symptoms. Moving forward, the psychotic phase is going to be this person's time when we start to see those psychotic symptoms. And so those are going to be the symptoms that I shared with you guys on the previous slide. So that's going to include those delusions, hallucinations, disorganized speech, or disorganized behavior. So the psychotic phase, again, is defined by those psychotic symptoms, and that's kind of really what is prime at this point. Finally, the last phase is going to be the stable phase. This is the phase when we start to see negative symptoms really persist, but we're not seeing those psychotic positive symptoms quite as much. The main reason for this is that a person has begun treatment, and as we'll discuss later on in class, the treatments for schizophrenia are very good at dealing with the positive or psychotic symptoms of schizophrenia. They aren't quite as good at dealing with the negative symptoms, which primarily impact a person's ability to function. And so that's one of the reasons for entering into that stable phase, is that those symptoms are left untreated, and so they persist. Over the course of a person's experience with schizophrenia, they could potentially fluctuate back and forth between the stable and psychotic phases. If, for instance, they were to go on medication and then go off, or not stick with a particular treatment course, that could cause them to kind of waffle back and forth. But at the end of the day, once we have established treatment, theoretically at that point, the person is in a more stable phase. So how that timeline works out is that the psychotic phase has to last at least a month or less if successfully treated sooner. And then collectively, the prodromal through the stable phase must last at least 6 months. Although schizophrenia is very chronic in nature, and so this is something people live with for years and years and years. Some terminology that you'll see on this slide and that you'll see reflected obviously later on, and that we'll be talking more about negative symptoms, is the distinction of symptoms being either positive or negative in nature. In a nutshell, positive, I could get into the nitty-gritty of what those terms mean, but I just think it's a touch beyond the scope of this class, so I'm not going to kind of drill that into you. In a nutshell, just think of positive as being a synonym for psychotic, so those really active symptoms, again, delusions, hallucinations, disorganized speech, disorganized behavior, and then think of negative symptoms as everything left over. And again, we'll talk more specifically about what goes into the negative symptom category later on when we get to that symptom group. So delusions is our first symptom group that we're going to talk about more specifically. And again, there'll be one of these slides for each of those symptom groups. So we will talk about what each of these is. And I'll also give you plenty of examples. So hopefully you guys feel really secure in your understanding of these symptoms by the end of this lecture. So first we have delusions, and at the top of the screen, you'll see that I've labeled delusions with an asterisk because it's a critical symptom, and then also the plus sign, again, reminding you guys that this is a positive symptom. And again, remember, for the intents and purposes of this class, positive means psychotic. So those active, hallmark really symptoms of schizophrenia. So again, a delusion is going to be a false belief. And as I mentioned earlier, these are really rigid in nature. So this isn't simply a belief or opinion that maybe you could debate with a person with, and they might kind of change their opinion. These tend to be very rigid in nature. The most common type of delusion is going to be a persecutory delusion. This is, in a nutshell, a belief that someone else is out to harm the individual. So someone's trying to get me, someone's trying to hurt me, someone's trying to kill me, stuff along those lines. Delusions of influence are going to be delusions, thoughts relating to the idea that the individual's thoughts or behaviors are either being controlled or monitored by others. So someone else has implanted me with some mind control device where they are controlling what I think or what I do, or they are surveying me so they can kind of see everything that I think or feel, or see everything that I do. Delusions of significance or self-significance are delusions that relate to an object, event, or even the person themselves as being more significant than they really are. We did cover an example of both delusions of self-significance and just plain significance. If you think back a couple lectures to when we covered mania in the context of bipolar. If you guys remember John, the manic mechanic from that video you watched, he believed that he had the cure for cancer, and that he had this information on the basis of newspaper clippings that he had gathered, and that he was in communication with God, and that was how he got that information. So this is a really good example of this type of delusion, that he believed those newspaper clippings were more significant than they really were. In reality, they were just, trash. And he also believed in a way that he was more significant than he was. He spoke in a really grandiose way, as if he was better than, his family and friends around him. And obviously he is significant in his own mind, and that he's kind of the special one who's communicating with God. If the idea of delusions interests you, specifically the idea of delusions relating to self-significance, I'd encourage you to read the case study about the 3 Christs of Ypsilanti. This is one of those famous old school kind of psych case studies that's super interesting, happened mid-century in the 1960s, but would never in a million years happen today. In a nutshell, it's written by a guy that was working at at an asylum in Michigan, and 3 of the patients at this asylum had the same delusion of self-significance. Specifically, they all believed that they were Jesus Christ reincarnated. And so what he did was he put the 3 of them together, and the idea was that he was going to let them kind of talk it out, so to speak, to figure out who was really Jesus Christ and who was not. At the end of the day, they decided that one of them was and the other 2 weren't. So, I mean, definitely not a treatment approach I would recommend, or one that, again, would be done in a million years today, as, you know, it kind of helped the 2 guys out, but it definitely ingrained the delusion in the 3rd guy. But again, if you kind of really enjoy reading about old school psych stuff, and the idea of delusions or schizophrenia is interesting to you at all, this is probably up your alley. Finally, the last type of delusion I'll highlight, and this is not an exhaustive list, these are just some examples either that I'm sharing because they're interesting or because they're common, but a somatic delusion is going to be a belief relating to one's body. So it is important to distinguish a somatic delusion from a tactile hallucination, which I'll introduce on the next slide. Remember that a hallucination is relating to the sensory experience versus the delusion is just the belief. So a somatic delusion is a belief about one's body versus a tactile hallucination would be feeling something in relation to one's body. So an example of a somatic delusion might be believing that one's body is rotting from the inside out, not actually feeling that one's body is rotting, but believing it. A tactile hallucination would be a false sensation. So if someone was feeling that their body was rotting or was feeling a formication or that sensation that one has creepy crawlies on them on their skin, and that was a sensation they were experiencing despite the fact that it's not really happening, that then would be a tactile hallucination, which encompasses about 15% of all hallucinations. Hallucinations in general, as you guys will remember, are false perceptions, and they can impact any of the 5 senses. These are also going to be a critical symptom and also a positive, psychotic, or active symptom, depending on which of those synonyms you're kind of identifying with today. The most common type of hallucination is actually auditory. It's not visual. Auditory hallucinations account for about 3/4 of all hallucinations impacting folks with schizophrenia. They most often have a negative valence. It may be one or more voices, and the voices may be speaking to the person or about the person. So they really vary, but the biggest take home is really that negativity point. This isn't necessarily the case for everybody, but the vast majority of auditory hallucinations are negative. So that means that, you know, this isn't like this person has their own personal cheerleader or cheer squad in their head telling them how great they are. These voices typically tend to be pretty berating, mean, cruel, harsh. And again, it can be one, multiple, and they can be speaking to the person, or it can be kind of more of a peanut gallery talking about the person. Visual hallucinations actually tend to be a hallmark of very severe cases. So if someone is seeing something that's not there, that is an indicator of more severe schizophrenia. And these really only impact about 14% of folks with schizophrenia. Common things that people will report seeing are religious figures or deceased individuals. But again, with schizophrenia, we're typically talking about more of a negative valence. So this wouldn't really be angels or a loved one. This might be demons, more satanic figures, or maybe someone who's passed who this person didn't have a great relationship with, something like that. We've already touched on tactile, but then the last 2 are going to be olfactory and gustatory, which are jargony ways of saying smell and taste. These are going to be the least common, and again, negative valence is pretty common. So, you know, smelling rotting eggs, tasting garbage, stuff like that. And again, all of those things aren't real. The person is experiencing the sensation. Those areas of their brain are kind of lighting up, but the thing is not actually happening. Disorganized thinking is going to be our final critical and positive psychotic active symptom. While disorganized thinking is what we're really looking for, at the end of the day, we can't really tell objectively what a person is thinking. And so what we're actually looking for diagnostically is going to be speech abnormalities. And we can kind of infer based on how a person is speaking, how a person might be thinking. So again, not an exhaustive list, but some examples of things we may see. One is going to be a loose association. So a person may say something along the lines of, I once worked at an army base, soldiers are important, the Middle East, I like to travel, I love Arizona. So you guys can see just by looking at that string of sentences that it really communicates nothing. It makes little sense. But you can see how the person jumped from one sentence to the next on the basis of, a similar theme. So army, soldiers, Middle East, travel, Arizona. So that would be a loose or tangential kind of association. And that's indicative of loose or tangential thought. So the person's not kind of thinking logically or clearly, but their brain's kind of bouncing around to a bunch of different topics. We may see long pauses in speech, and this can be indicative of thought blocking, which is where a person pauses their speech to intentionally try and block out another one of these active psychotic types of symptoms. So a person's actively hallucinating or is really wrapped up in a delusion, and rather than trying to continue talking while also dealing with this very distracting experience, they'll kind of pause in the middle of a sentence and intentionally try to block out like whatever it is that they're hearing, for instance. Finally, we may also see a clang association. This is kind of similar to a loose association that, again, a person's not really thinking clearly or in a straightforward fashion, but instead their speech is kind of brought together otherwise. In this situation, more by alliterative types of processes. So a person might be speaking based on alliteration or rhyme, things like that. So a person may say something like, I have bills, summer hills, bummer, drum solo, polo. So imparting even less sense than we got from the loose association. But again, we can kind of see how the person got from A to B. In this case, it's on really the basic of rhyme. Disorganized behavior is going to be a psychotic, positive, active symptom. It's not a critical symptom, though, meaning that some folks have it, some folks don't, but it's not among one of the three symptoms that a person must have. Disorganized behavior, kind of like disorganized speech, it's something tangible, objective that we can see, that is indicative of a person's thinking and, brain basically becoming more chaotic. Catatonia is going to be the most common manifestation of disorganized behavior, and so that's really what I'm going to focus on here today. Catatonia in a nutshell is actually a very broad definition that encompasses more behaviors than most folks realize. It's basically when a person is awake but unresponsive to external stimulation. So a person could be moving, they could be laying down, they could be maintaining eye contact or staring off into space. They could be speaking or not. They could be rigid or waxy. Rigid is when a person is firm, so like you could try to move them and they'll resist. Their muscles are flexed and tense. Waxy would be when a person I always use Gumby as an example, but that's kind of an outdated reference. But it's almost when a person's kind of like Play-Doh, and you could walk up to them and move their arm, for instance, and they would allow you to kind of move their body into a new position. Some great examples you'll find on this clip that I have linked to here. You'll see links on As You Learn in the syllabus as well. I suggest pausing and watching it now just to kind of cement your idea of catatonia, but you'll see examples pretty much of all of this in here. So again, catatonia, much broader than most folks realize. It's not necessarily just a person lying still on the bed. A person, again, just has to be awake but unresponsive. And this could include a person who's mobile. So a person who's pacing across the room back and forth, and you try to get in their way or snap them out of it. And they're just kind of moving around you and just really in the zone and unresponsive to you or anything else in the environment. Finally, we've got the negative symptoms. So negative symptoms is basically everything else that doesn't fall into one of those previous categories. The term negative comes from the fact that the symptoms we've talked about previously are like these active symptoms. These are symptoms that we're seeing kind of beyond the norm in folks with schizophrenia, symptoms that we're seeing from people with schizophrenia that we're not seeing from other folks. This is kind of the opposite, though. These aren't kind of added things that we're seeing, like delusions or hallucinations. Rather, these are more the absence of normal behaviors. So, for example, we would expect a regular healthy person to demonstrate emotional expression when they speak. So, I mean, I'm not just speaking in monotone, my voice is going up and down over the course of this lecture to kind of emphasize different points. Versus if I had diminished emotional expression, I'd be talking in a very flat way, or inappropriate emotional expression would be, laughing when talking about something sad or serious or depressing, something like that. So this is a negative symptom because appropriate, healthy emotional expression is something that we see from healthy folks, but either diminished emotional expression or inappropriate emotional expression is something we see in folks with schizophrenia. So it's not really this added symptom like a delusion, it's really more the absence of a healthy behavior. So that's kind of where the idea of the negative symptom comes from, if that kind of helps you make it kind of more, why am I stumbling over this? If that makes more sense for you in your head to think of negative symptoms that way, then by all means retain that definition. But again, I'm not really going to be quizzing you guys on that in this class. For those of you where maybe that description wasn't quite making sense, just think of negative symptoms as everything that's not in one of those 4 categories that we already went over. Anhedonia is going to be that familiar depressive symptom, so we can see that here as well. We could also see a lack of motivation, which, avolition and apathy are going to be synonyms for that. Alogia is a really interesting symptom. It basically means a decreased quantity or quality of speech. So this is different than disorganized speech. So remember, disorganized speech is indicative of disorganized thought. Alogia, though, is just when a person either isn't speaking a lot, may even be mute, or they're starting to slur their speech and the quality of their speech has really gone down. So again, not necessarily disorganized thought, but more just an indicator that this person is no longer hitting the benchmark of normal, healthy, easily transcribable speech. And I'm going to show you guys here in a moment another video that I'm going to want you guys to pause and watch. And this second video is 4 different people with schizophrenia, which I love because schizophrenia is so varied, as you guys have already probably glimpsed from these slides. There are so many ways people can meet the criteria. And so one of the great things about this video is it shows you 4 different examples, very different examples of schizophrenia, and you can see the difference between alogia and something like disorganized speech. So be looking out for that in particular, because that's kind of a distinction that I've had students kind of trip over in the past. We may see psychomotor retardation, again, another familiar depressive symptom. We may see cognitive impairment. So for example, we may see a person who can't think in a more kind of abstract or metaphorical way. So if you asked a person with schizophrenia, what does the phrase people who live in glass houses should not throw stones mean? They might reply, well, like build a house out of bricks, not really demonstrating the ability of, being able to think in a more literary way, or kind of thinking beyond to alternative levels of meaning from that particular saying. We may see social impairment, a lack of social skills, poor hygiene, poor self-care, things like that. And again, as I mentioned briefly earlier, one of the reasons that the stable phase of schizophrenia is different from the psychotic phase is because once a person is prescribed antipsychotic medication, that medication addresses the dopamine levels, which is responsible for the positive psychotic active symptoms, but it does not address the serotonin levels. And at the end of the day, another difference between the positive and negative symptoms is that the negative symptoms are driven primarily by serotonin, very similar to depression in many ways, versus again, the positive symptoms are driven by dopamine. And so because the medication impacts one but not the other, we see that the negative symptoms persist into the stable phase. As I mentioned earlier, here's your video for those 4 cases. I would highly recommend pausing to view that now that those symptoms are fresh in your head. Be keeping a list of each of the 4 symptoms and each of the 4 cases and each of the symptoms that you see across those cases. That'll be one of the big things that we end up discussing more so in class. So, one of the next things that I want to talk about now that we have fleshed out the idea of schizophrenia is to talk about some of the similarities and differences between schizophrenia and some of the other diagnoses that we've either talked about in this class or will talk about. One of them is autism, which is a diagnosis that we'll get to a bit later on. Autism is kind of a funky one. I remember when I first learned about schizophrenia and autism, I was like, what? Like, those are completely different things. How could people get them mixed up? At the end of the day, though, schizophrenia and autism entail people who are thinking differently than folks without those diagnoses, people who are perceiving the world differently, and people who are behaving a little bit differently as well. And so, if we rule out and kind of exclude the presence of things like delusions and hallucinations, which are very obviously associated with schizophrenia and not autism, and we're really just dealing with like disorganized speech, disorganized behavior, negative symptoms, it can be pretty difficult actually to parse out the two. So, for example, someone with schizophrenia may have a delusion, which, as we've established, is a false belief, but it's also a very rigid false belief. Versus someone with autism, while having a false belief isn't necessarily typical, it's very common for folks with autism to have routines and specific ways that they like to do things and specific ways that they like to think about things. And so this rigidity in thought is very common. Similarly, alternative perceptions are very common. In the case of schizophrenia, we may have a hallucination. In the case of autism, you may have someone who like cannot touch velvet or some type of fabric because it just feels awful, or a person might have an affinity for a particular fabric or texture. Folks with autism may also not eat certain foods on the basis of how they feel. Folks with autism might also have really magnified auditory experiences where, something like a whisper or even something somewhat loud like grinding coffee just feels deafening. Folks with autism can also have visual perceptual differences where lights feel really harsh. And so, again, some overlaps. Disorganized behavior may be common across both groups. So, you might not see full-blown like catatonia for instance, although you could see some potentially disorganized types of behavior from folks with autism, like potentially pacing or flapping types of behaviors. And then, of course, you could see negative symptoms across both groups, symptoms that are impacting a person's ability to communicate, maybe so far as mutism. You may see an impact in socialization across both groups as well. Another symptom that might impact both groups might be something like echolalia, which is a jargony term for repeating something a person just said. So a person with autism can definitely engage in that behavior, but someone with disorganized speech whose brain is not creating forward types of thoughts, as in a case of a person with schizophrenia, could simply repeat what a person just said as well. So at the end of the day, it is important to rule out autism before diagnosing schizophrenia, and hopefully now you guys might realize some of the reasons why. And if you are diagnosing a person with autism with schizophrenia also, it's important to really look for those symptoms that are unique to schizophrenia and don't overlap with autism, delusions and hallucinations being the prime example. So that's kind of typically when you would move ahead with the second diagnosis. Otherwise, I personally probably wouldn't, just because autism can really account for some of the other pieces of schizophrenia. Schizophrenia and substance use. About half of people with schizophrenia have a substance use disorder. One of the reasons for this is the self-medication hypothesis. Basically meaning that whether the person is on an antipsychotic or not, those negative symptoms are definitely still there. So you either have a person on an antipsychotic medication with negative symptoms, or a person without antipsychotic medication who has both of those symptoms, positive and negative. And so substances basically exist as a fairly cheap, accessible way to numb those symptoms and self-medicate. And at the end of the day, research suggests that, at least to a degree, this may be a somewhat successful approach, depending on how you want to quantify success. In that correlational data show that folks with schizophrenia who also have a substance use diagnosis are less likely to experience negative symptoms. And so that numbing effect seems to be helping, which is why we see so many folks with schizophrenia using substances. Beyond that, there's also a socioeconomic link. In that folks with schizophrenia tend to be of a lower socioeconomic status. Some of this may be associated with what's called a downward drift, which basically means that a person started off at a higher socioeconomic status, was diagnosed with schizophrenia that caused negative impact relating to their ability to socialize, to hold down a job, et cetera, et cetera. And so the person began to drift downwards on the socioeconomic ladder, where things like substances are more regularly or more often available as a way to treat symptoms versus access to like an antipsychotic medication, for instance. I also want to point out while on this topic that substance users are actually the most violent group within the DSM. I point this out because schizophrenia has a really bad reputation, and this goes back to what we talked about what feels like forever ago when we went over language and the idea that, you know, in talking about violence, you should never really talk about whether or not the person has a mental health diagnosis, because even if they do, that is just simply not a representative case. The vast majority of people with mental illnesses are not violent. And when we highlight that a violent person has a mental illness, it just perpetuates that myth that everybody with mental illness is violent, when again, that is just simply not the case. And schizophrenia is one of those diagnoses that everybody thinks is associated with violence. At the end of the day, though, the most violent group, again, the DSM, is going to be substance users, because these folks, when actively intoxicated, you know, their brain is functioning on a different level. They may be more impulsive, less inhibited, more likely to do something dangerous. Similarly, if a person is in withdrawal and really kind of needing, craving more of their substance of choice, they may be more willing to go to extremes than another individual. Only about 8 to 15% of people with schizophrenia commit crimes, whereas about 16 to 34% are the victims of crimes. So those are important statistics to kind of keep in mind. Why then, though, is schizophrenia so commonly associated with violence, at least in the media and in the minds of so many people? Some of the reasons go back to deinstitutionalization in the 1960s, which is when all of those asylums that contributed to things like the Three Christs of Ypsilanti closed, which was a good thing. You know, these places, at least as they operated in the 60s and prior, were not healthy environments. They were not really aimed at helping patients to feel better and recover. They were more aimed at removing people who weren't considered normal, whether those are folks with schizophrenia or bipolar disorders or even things like autism, from the rest of the population, and just kind of giving them a place to live out their days, and again, just kind of removal. So deinstitutionalization was the process of closing down these hospitals, these institutions, but there wasn't really a place for patients to go otherwise. So that's kind of where this process really fell short. And so many of the folks that were in these institutions ended up homeless. And because the homeless population is a population that most people don't have much interaction with, don't really know much about, it's common for people to fear that which they don't understand, they don't have experience with. And so fear mongering is something that has kind of brewed this link between schizophrenia and violence. But again, it's really just this kind of feared association between a group of people that most folks don't really understand. And again, at the end of the day, the most violent group in the DSM is going to be substance users. The final diagnosis that I want to talk about here in terms of its relation with schizophrenia is something called dissociative identity disorder, or DID. This is what used to be referred to as multiple personality disorder, and that's probably the term that you guys are more familiar with. I cover this disorder here because it's commonly confused with schizophrenia. It's a completely different category of disorder. It's a dissociative disorder versus schizophrenia is a psychotic disorder. So they're completely different categories, but the media really misrepresents these two. Great example would be, again, kind of a dated reference, but it's a classic, really clean one, so I keep using it. The Jim Carrey movie, Me, Myself, and Irene, where he has two personalities who are both in love with the same woman, who I believe is played by Renee Zellweger. And he's referred to as being schizophrenic repeatedly throughout that movie. And that's a very common thing for movies to show someone with DID or MPD, but be referred to as schizophrenic. And so again, even though this is a dissociative disorder, I like to cover it here just because of that media misrepresentation. So these are two very different disorders, and multiple personalities is not schizophrenia. Some reasons for the confusion, in addition to media misrepresentation, is that schizophrenia literally means split mind. It was named this to connote the fact that folks with schizophrenia frequently split from reality, not that their mind has split into multiple personalities. In addition, some people may confuse an auditory hallucination with a multiple personality, but they are very different. People with multiple personalities, their personalities aren't frequently communicating with one another. The person might not even be completely aware of different personalities or the fact that they're switching from one to the other, and they might actually have memory loss for periods of time between the personality states. Versus an auditory hallucination, the person is always themselves. They're always the singular, stable personality. There's just a voice in their head that's talking to them or about them. Both of these things tend to be the epitome of severe psychiatry. You know, when you think of asylums and institutions and modern day inpatient units, and you think of schizophrenia, you think of multiple personalities, you think of maybe even bipolar disorders. So these are kind of the big things. And again, most people don't really understand these diagnoses. And so there's kind of that fear mongering, very similar to what we talked about with the homeless population. It's very common when people don't understand things to simply be kind of afraid and to kind of lump things together. And so potentially schizophrenia got lumped in with multiple personality disorder because they're both these rare things that most people don't understand at a greater level. So let's talk for a minute a little bit more about dissociative identity disorder, multiple personality disorder. It's a really funky diagnosis, and so that's really the reason I want to talk about it a bit more versus simply moving on. So the origin story of DID goes back to the 70s when a book called Sybil came out. And Sybil was supposedly the true story of a patient named Shirley Mason, and the book was written by her provider. I can't remember if Flora Schreiber was a psychologist or psychiatrist, but either way, provider wrote the book with the permission of the patient, Shirley Mason. And Shirley Mason supposedly had 16 different personalities. So this was a really groundbreaking, interesting book, caught the attention of people worldwide, both lay people and professionals. But what happened following the publication of this book, which led to TV shows and was really kind of the inspiration even behind movies that come out today, like Split, for instance. But what happened is that worldwide cases increased from like 79, 80 cases worldwide in 1970, so basically non-existent, to 6,000 cases in the 80s, 10,000 plus cases in the 2000s. So huge exponential increase with respect to diagnosis. And that's just not something we see. You know, when we see a new memoir written about a bipolar diagnosis or a perinatal depression, we don't see the diagnosis of those things go up, but we did in this case, which indicates that maybe there's something else going on, because when we have kind of this true, authentic thing, it's not impacted by media and cultural interest in it. So at the end of the day, Shirley's case ended up being a fake. Not a malicious fake. It's not like she had a factitious disorder and was intentionally faking, or that her practitioner was making it up. This woman really was presenting with 16 personalities, but it wasn't really genuine. At the end of the day, it seemed that her provider was engaging in coercive therapy, meaning that this woman, this provider, was potentially interested in the idea of multiple personalities and was asking suggestive questions like, well, what did your younger self think about that? Or I want to hear more from the younger version of you, or I want to hear more from the um, stable or teenage version of you, or whatever. Coercive types of questions like that, particularly from someone who's not really getting much attention or reinforcement elsewhere, can, on a very subtle level, motivate that person to provide the answers that it seems like the other person is seeking, in order to continue to gain access to that attention. So some attention seeking may have been a piece of this, combined with early psychotropic medication was really a doozy. You saw lots of really intense tranquilizers and things like that. So 60s, 70s era medication would have definitely put Shirley in a very different altered state of mind. She also had a trauma history, so she was a very vulnerable woman as well. And so these combined forces basically um, pulled out of her these personalities that wouldn't have presented themselves had it not been for this particular context. And the thing, again, about other diagnoses is that depression's depression, anxiety's anxiety. It's not something that's pulled out of a person or manifested or not. And what's really interesting is that subsequent cases of DID are very similar to Shirley's original case. Tons of alters, so we're talking 16, 21 personalities. There's frequently a trauma history, and about 80 to 100% of these alternate personality states appear after the person's begun therapy, suggesting that similar inappropriate coercive, again, not malicious, not misintentioned, just misinformed coercive therapy techniques are playing a huge role in kind of pulling these alters out of a person when they wouldn't have been there previously. And so at the end of the day, the sociocultural model is the prevailing model behind multiple personalities, which basically states that it's the environment, specifically this particular brand of therapy, plus media representation that creates DID. So how does media play a role in this? Like, I've kind of already talked a little bit about therapy and how different questions can maybe pull this out of a vulnerable, traumatized, medicated person. But what about media? Media, at the end of the day, is how many people learn about the world around them, mental health included. And it's common for people to believe what they see in the media. And so if they're seeing these stories about people with multiple personalities, that connotes this idea that this is real, this is something that can happen. And so then when you have a therapist who is asking you questions about your younger self or other tricky questions, or listen up everyone when the therapist is really just talking to the one person in the room, that stuff feels like it makes more sense, because it's like, okay, well, maybe there is something beneath the surface. Maybe I have multiple personalities and this person's going to pull it out, versus not having that media normalization. Clearly, if we go back to before this book came out, it wasn't as normal for patients to kind of go along with this because the media had normalized the presence of multiple personalities. And research has actually backed up the sociocultural model. So for instance, healthy control subjects, when given appropriate cues, can produce DID-like symptoms. So basically what this means is when researchers bring healthy, normal participants into the lab and give them these appropriate therapeutic coercive cues, we can start to see gradual DID-like change. Beyond that, research also suggests that the more the therapist believes in DID, the more likely it is the patients will be given the diagnosis. So basically, when a therapist is looking for it, they're asking those leading questions, particularly of this traumatized, attention-seeking, possibly medicated group. It's very likely that that combination of events will kind of create this disorder. So is this disorder real? It's definitely not the same as the other things we've talked about. It's very cultural. you could even kind of potentially conceive of it as being culture bound potentially, and that it seems to be specific to areas with this therapeutic approach and this media coverage. It's not historical, which is interesting. So with most other things in the DSM, you can go back and find, artists from hundreds of years ago that have bipolar disorders, and we talked about that and talking about those particular disorders. You can find people with personality disorders, depression, autistic-like disorders, but historically you just don't see these genuine cases of people with multiple personalities, which again is strange. However, that being said, to kind of flip the script and play devil's advocate a little bit, there are a few modern cases that are really cool, in which I'm talking cases, so like a person, two people, in which individuals have demonstrated impressive cognitive differences between one personality state and another. So for instance, there's this one case of this individual who can write right-handed in one personality and left in the other. And again, it's not factitious, like this person is ambidextrous and has trained themselves to do both and is kind of putting on an act. Legitimately, brain scans are indicating that the brain is functioning differently. Another individual, another funky case that I'd read, this person at like an optometrist getting your eyes tested, their vision was different across different personalities. So there does seem to be some evidence that the brain may be capable of functioning very differently in different states. But the idea of someone having 16 personality states, the idea of someone murdering someone in one state and then forgetting about it, all of these very popular movie tropes, that's really all it is it's movies. And if someone is acting like that in real life, it seems to be in large part due to that media coverage in the first place and also misinformed therapeutic approaches. Okay. So getting close to the end here, guys. I know this lecture is a little bit longer and again, concentrated on this one diagnosis, but again, it's just simply because, this is interesting and it's also something you guys are probably less familiar with. Schizophrenia impacts about 1% of adults, about half are comorbid. Females are diagnosed with milder schizophrenia and later than males. With a lot of, let me back up for a minute. So age is an important piece of diagnosis. Males tend to be diagnosed at a younger age, late teens to early 20s. Females tend to be diagnosed mid, late 20s, maybe even later 30s. And males tend to be diagnosed with a more severe version of schizophrenia compared to females. Age may have a role in that. So if women are being diagnosed later, that means that they're late 20s, early 30s. They've lived a lot of life. They've gotten through college. They have a job. They're more mature at that point. And so they're going to be better able to handle those symptoms versus if we're talking about an 18-year-old guy, that person has relatively less life experience. And so the symptoms are going to hit much harder. Beyond that, some additional hypotheses suggest that because women tend to have more developed social groups, that social piece might be buffering and protective. Some other researchers point to the role of estrogen maybe in women tending to have milder symptoms. But at the end of the day, you should know that women tend to have milder symptoms and experience schizophrenia later than men. There's also a racial bias favoring the diagnosis of schizophrenia among the African American population compared to the white population. And this is despite there not really being a true racial difference in diagnosis. I have an associated reading that I'll have you guys go over that delves into that topic a bit more. So I won't talk more about that here, but that's definitely an important take-home point. Suicide risk is highest at the onset of symptoms and immediately before and after hospitalization. The first two of those probably make sense. Most students are confused about the after hospitalization piece, like, well, shouldn't this person be feeling better and not be at a high suicide risk? At the end of the day, anybody leaving a psychiatric hospital is at a higher risk for suicide, simply because hospitals are so structured, there's such routine that particularly if a person went in there for suicide, it's very easy to stay stable while in the hospital. But when all of that routine is removed all at once, that can leave that person vulnerable again. And so it's important to know as a professional, as a friend or a family member, to kind of look out for that person post-discharge. Self-harm is very high for this population as well. And entering into an environment of high expressed emotion, meaning loud negative emotion, can put this person at an increased risk for relapse. So if this person is going back to a living situation where people are yelling all the time, there's a lot of negativity, that is not a great environment for that person to be in. Causes of schizophrenia are varied. The dopamine hypothesis suggests that excess dopamine levels are associated with the positive psychotic active symptoms, and so that's why people with schizophrenia get it. Genetics is another piece of it. There's a 60 to about an 85% monozygotic concordance rate, meaning that if one identical twin has schizophrenia, there's a 60 to 85% the other twin will as well. Some research also points to prenatal viral infections increasing the risk of schizophrenia. But anyway you slice it, these are all very biological explanations, indicating that schizophrenia more so than something like a depression or an anxiety, which yes, genetic piece is there, but definitely much more environmental. So schizophrenia is definitely one of our more biological diagnoses. Treatment at the end of the day predominantly is pharmacological or medication based in nature. Specifically, antipsychotic medications are prescribed to block dopamine receptors. So to understand the idea of a dopamine receptor, we have to back up for a minute and explore how brain cells work in the brain. So our brain, our nervous system in general, is made up of these cells, and they don't exactly touch. They're very, very small, and there's actually a very small gap between each brain cell. And what happens when the brain cells are communicating between one another is these neurotransmitters are released into the gaps between the brain cells. And neurotransmitters include things like dopamine, norepinephrine, serotonin. And so these chemicals are released and they dock onto the receptors of the postsynaptic neuron, which basically tells that next neuron to communicate to the next one. It's almost like a series of dominoes, but with chemicals being the tiny little building blocks that contribute to knocking the next domino over in a line. And so the idea is that if people with schizophrenia have too much dopamine, then we'll prescribe these dopamine blockers, which will sit on the dopamine receptors and prevent that dopamine from sitting there. And so hopefully this will improve positive symptoms. And at the end of the day, that's what happens, at least initially, is the person's positive symptoms do improve, and there ends up being minimal impact on negative symptoms. Some negative symptoms actually get worse through the use of antipsychotic medications. Medication tends to be the first line of treatment. With respect to mental illness in general, it's a very Western approach, but particularly with the more severe diagnoses like schizophrenia, it's definitely the first line of treatment. So I typically don't talk a ton about treatment in this class, so you may be wondering why I'm showing you guys these graphics about medication and talking about it more. One of the reasons that I like to talk about medication more in the context of schizophrenia is, it's the first line of defense. It's really kind of like the gold standard, I guess, for schizophrenia, but again, medication is also used for a variety of mental illnesses, and there's some funky things about medication that not a lot of people realize. And so I do think it's important to talk at least a little bit about medication, just so you guys have a better idea of how it actually works. So what happens anytime a person takes a psychotropic medication, whether it's an antipsychotic, an antidepressant, an anxiolytic for anxiety, whatever, you take a drug, it's doing something to your brain. The brain doesn't like it. Regardless of what the drug is doing, brain, body in general wants to maintain something called homeostasis, which is a fancy way of saying the status quo. So no matter what the medication is doing, your brain's not going to like it. Your brain wants to continue doing what it's doing. And it does this by actually changing the body's anatomy and physiology. So if you start taking a dopamine receptor blocker, what's one of the things that the brain does? It will actually grow more receptors on the postsynaptic neuron to account for the fact that the antipsychotic medication is blocking some of those receptors. So you see there's a big difference between graphic A and graphic B on the slide. Graphic A is like 4 dopamine receptors, graphic B has 7 dopamine receptors. And so what's ironic at this point is that if this person ever were to stop their antipsychotic medication, now they truly would have a dopamine problem because they've got twice the number of receptors as they did to begin with. This is something called oppositional tolerance, which is a fancy way of saying that the medication ends up causing what it was intended to treat. So again, medication was prescribed because this person was thought to have an excess dopamine problem, but now they do have a dopamine problem because their brain has grown these excess dopamine receptors. And at the end of the day, this data that I'm showing you on the previous slide, this idea behind this dopamine hypothesis, and people with schizophrenia having more dopamine, that data is very correlational in nature. We don't know what came first, the chicken or the egg. So did the person have excess dopamine and that's what caused the schizophrenia, or did the schizophrenia cause the excess dopamine? Or potentially some third variable is that antipsychotic medications end up causing excess dopamine levels through this process of oppositional tolerance. So the medication does seem to work initially, but that's before the body starts adapting. So the positive symptoms are impacted, but frequently if medication is going to work long term, the provider has to adjust dose and maybe even the type of medication because the brain's trying to counteract what you're doing with the medication. Which is a kind of a fancy way of implying that tolerance is happening. The brain is trying to combat what you're doing, tolerance is building up, and so you've got to take more and more of it to combat what the brain is doing. So at the end of the day, medication may not be as effective in the long term as we thought. And this is a very common phenomenon that we're starting to see more and more across mental disorders. So what this graph is showing is the long-term recovery rates for schizophrenia patients. So this graph is comparing how patients are doing 2 years following treatment all the way up to 15 years following treatment. So you'll see that there is only about a max 10%-ish recovery rate among folks on antipsychotics, but among folks off of antipsychotics, there's almost a 45 to 50% recovery rate, indicating that again, while you might see immediate improvement once a person begins a medication. Again, whether we're talking antipsychotic, antidepressant, anxiolytic, you see that immediate improvement because the brain hasn't yet responded, hasn't tried to defend its homeostasis. But once that process starts, you start to see less and less of an effect in the long term from medication, and in particular, and you can see these type of data across depression, anxiety, everything, that if you start to compare groups of patients on and off medication, those off medication are typically doing much better 10, 15, 20 years down the road than people on medication because their brain chemistry hasn't been completely scrambled. So how does medication fit in? The way I use it, and I don't prescribe, but the way I refer people to other folks to prescribe medication or not, is that I always like to talk about what's happening in the brain. And if I am referring a person to a prescriber for medication, I typically only do so after I've engaged with therapy. And if I'm just kind of hitting a wall where it's like, this person is so, I don't work with schizophrenia in my practice, but if this person is so depressed, so anxious that like what I'm talking about in therapy isn't even clicking or landing with them, then I'll potentially refer out for medication. And the way I kind of describe this to my patients is, we just need to lift the fog a little bit to the point where you, as a healthy person, can hear what I'm saying and engage in these interventions. Because right now, this anxious, depressed version of yourself is not hearing what I'm saying and is not engaging in what you need to engage in to feel better. And so I always pitch it as like we're temporarily lifting the fog so that therapy can kind of take hold, and that the plan down the line is that we're going to come off of medication. We don't want to be on medication forever. I recommend that a person not stay on medication for more than 2 years. And this isn't to say that if you've been on medication or you have a patient who's been on medication more than 2 years that they're screwed. It's just that we're seeing more brain change at that point. And so it's just going to be harder to come off. Um, in some cases, it could be near impossible. So if you're thinking about this for yourself, this is definitely something to talk to your own providers about. But as far as my practice goes, thinking more proactively versus retroactively and trying to undo stuff, I recommend that no one stay on medication longer than 2 years, and that we use it as kind of a temporary fix to aid the efficacy of therapy, and that we utilize more psychosocial treatments to address underlying change. Psychosocial treatments for schizophrenia that may be helpful are things like psychoeducation. Knowledge is power. Just knowing what's going on can be so helpful for patients, for family, friends, loved ones. Mindfulness-based approaches can help people to just kind of tolerate distress and what's going on, versus fighting it. And that might seem like a strange approach, but just tolerating distress and not fighting everything, whether it's a hallucination or anxiety or depression, can just help it just exist. And that acceptance style approach can be really effective. Social skills training for schizophrenia can be really helpful too, retraining skills that have been lost, helping people to get the basics down, maintaining a job, reinvesting in interpersonal relationships. Those can all be super helpful things that can help make schizophrenia a more livable diagnosis with a good quality of life, versus a person kind of remaining on medication and just being really drugged out and numb, and not fully recovered. Because really the projections of medication for schizophrenia is that this will dampen the symptoms, but there's not really a prescriber out there who would be giving you an antipsychotic for schizophrenia who would be promising you rainbows or that you're going to fully recover. The idea is that the medication is helping you to manage and kind of keep this under wraps, but the idea of recovery is typically not something that's discussed, versus that could be something that could be attainable by using more psychosocial treatments. And I mean, you'll see this slide, it's not 100% recovery. So schizophrenia is definitely very chronic. It's definitely a very intense diagnosis. But at the end of the day, more of the long-term research around all medication is indicating that it really might not be the best long-term approach. It may be more helpful to be used acutely for a brief period of time, but not long-term. So again, I present this in the context of schizophrenia, but the gist of that brief review of medication can be applied across all psychotropic drugs. Okay, so that is all that I have for you guys. Bring any questions that you have to class. Hopefully you guys have some, because again, this is a less familiar subject than something like depression or anxiety. And I look forward to talking with you guys about schizophrenia more.